at this ASCO, we have results of a large randomized trial, Persephone study, with more than 4,000 patients comparing 6 months to 12 months. And that has shown non-inferiority of 6 months, which really puts a wrinkle in our decision making, because previously we had shown that 2 years is no better than 1 year. We settled for 1 year after the FAIR study presented by Dr. Xavier Pivot, which also had more than 3,000 patients, and it could not meet the non-inferiority of 6 months. So 12 months remained the standard, and now we have to go back into debate and discussion about optimal duration of therapy in those patients. Then if we keep increasing the risk and now talk about patients with larger tumors or a number of positive lymph nodes, that's the subset which had shown benefit in the affinity trial of adding pertuzumab to trastuzumab, both given for 12 months in that setting. And there was not much benefit in lower risk patients. So even though the absolute benefit was small, we tend to offer doublet therapy in patients with high risk. Another data set came from Extenet trial, where patients who had completed 12 months of adjuvant trastuzumab were offered neratinib versus placebo. And we saw in that trial that overall result was positive for disease-free survival at 5-year follow-up mark, but subset analysis by surface markers showed only hormone receptor positive patients to benefit from that therapy. So now we have to take 2 separate data sets and see how we can combine them. And there's not any clear answer to that, and there are no plans to take an affinity type approach followed by a neratinib type approach. We have to take these data sets separately and maybe have a discussion of our uncertainties about these separate data sets with patients at the very highest risk with a lot of positive nodes.